Hi everyone, in this video we are going to demonstrate how to scan the knee joint by ultrasound. Here's a checklist for knee ultrasound examination. We will separate the knee joint into 4 parts, including anterior, medial, lateral and posterior parts. The anterior structures include suprapatellar, quadriceps tendon, femoral cartilage, and patellar tendon. The medial structures include medial collateral ligament, anserine, and medial meniscus. The lateral structures include iliotibial band, lateral collateral ligament, biceps femoris tendon, and lateral meniscus. And finally, the posterior structure include Gastrocnemius semimembranosus bursa, so-called Baker's cyst, and posterior cruciate ligament. To scan the knee, a high-frequency transducer of at least 10 MHz is used. The exception is the posterior knee, which a transducer of less than 10 MHz may be needed to penetrate the deep tissues. The routine ultrasound examination of the knee starts from the anterior aspect, followed by the medial, lateral, and posterior aspects. To evaluate anterior knee, we need the patient to lie down with knee extension and ankle dorsiflexion. Or you may ask patient to press knee to the bed. The transducer is placed in the sagittal plane proximal to the patella. You can see the suprapatellar recess. The suprapatellar recess is encircled by the suprapatellar fat pad and prefemoral fat pad. Normally, the thickness of effusion is less than 2 mm. Then, ask patient to flex the knee to 90 degrees. The transducer is placed in the sagittal plane proximal to the patella. The hyperechoic appearance of the quadriceps tendon can be appreciated. Make sure to scan from the medial to the lateral side. After that, ask patient to fully flex the knee. Place the transducers in the transverse fashion just proximal to the patellar bone. The femoral trochlear cartilage is a hypoechoic or anechoic V-shaped structure. Finally, flex the knee to 90 degrees to scan the patellar tendon. The transducers is placed in the sagittal plane distal to the patella. The hyperechoic fibrous structure extends from patella to tibial tuberosity is the patellar tendon. Make sure to scan till the most distal end insertion at the tibial tuberosity. If abnormality is noted, the patellar tendon should be scanned through the short axis view. Here, the transducer should also be floated on a layer of gel over the patella and proximal patellar tendon to evaluate it pre-patellar and infrapatellar bursa. In the medial part, we will scan the medial collateral ligament, pes anserine, and medial meniscus. For medial collateral ligament evaluation, the patient remains supine and slightly external rotation of hip joint. The knee is in about 20-degree flexion. The transducer is placed between the femoral medial condyle and the medial tibial plateau in the coronal plane. You can see the two different layers, the superficial and deep parts of medial collateral ligament. The deep layer of medial collateral ligament is separated by meniscus, so-called meniscofemoral and meniscotibial ligaments. Usually, medial collateral ligament is longer than the transducer. Make sure to check the entire ligament. The pes anserine refers to the conjoint tendon of sartorius, gracilis, and semitendinosus muscles. When scanning, the patient remains the same position as medial collateral ligament. Place the transducer 2 to 3 cm medial to the tibial tuberosity in a coronal oblique fashion. You can see the hyperechoic fibrillary structure. Usually, it is difficult to differentiate one from another at the distal insertion. When scanning medial meniscus, place the patient with supine and complete knee flexion. Place the probe in coronal fashion between the femoral medial condyle and the medial tibial plateau. The medial meniscus can be visualized with a triangular hyperechoic structure. To evaluate ultrasound of lateral knee, please make sure not to confuse Gerdy's tubercle with femoral head. The Gerdy's tubercle is the distal insertion of iliotibial band, while femoral head is the distal insertion of lateral collateral ligament and biceps femoris tendon. We will start from scanning the iliotibial band. Ask the patient lie in the lateral decubitus position with knee extension. Place the caudal part of transducer on the Gerdy's tubercle in coronal plane. You can see that iliotibial band presents as a hyperechoic band. The transducer is then moved proximally to evaluate the tissue between the iliotibial tract and the distal femur for disorder related to iliotibial band friction syndrome. Next, move the caudal part of the transducer to the femoral head in coronal plane and slightly pivoting the cranial part anteriorly. Due to anisotropy, the lateral collateral ligament is a hypoechoic structure. Compression with the proximal end of the transducer may minimize anisotropy. The structure beneath the proximal part of lateral collateral ligament is the popliteus tendon. Then, maintain the caudal part of the transducer at its position and pivoting the cranial part posteriorly. The hyperechoic structure is the tendon of biceps femoris. To scan the lateral meniscus, place the patient with supine position and complete knee flexion. The transducer is placed in a coronal fashion. The lateral meniscus can be visualized with a trapezoid hyperechoic structure. Sometimes, a pulsating hypoechoic vessel belongs a branch from the inferior lateral genicular artery can be seen within the lateral meniscus. You can open the power Doppler to confirm the vessel. To scan the posterior knee, the patient turns prone with knee extension. We will evaluate the Gastrocnemius semimembranosus bursa and posterior cruciate ligament. First, place the transducer in a transverse fashion at the medial portion of the popliteal fossa. At this site, the semitendinosus tendon, semimembranosus tendon, and medial gastrocnemius muscle can be noted. Normally, there is no fluid detected between semimembranosus tendon and medial gastrocnemius muscle. Baker's cyst is diagnosed when anechoic fluid is seen in this location. Once Baker's cyst is identified, the transducer is then turned in the sagittal plane to evaluate the extent of the Baker's cyst, assess for rupture, and whether the cyst communicates with knee joint. Last, place the transducer at the oblique sagittal plane. The cranial part of the transducer shows slightly medial in the direction of medial femoral condyle. The posterior cruciate ligament is a hypoechoic structure as a result of anisotropy. Remember not to misinterpret the hyperechoic fat plane as the ligament itself. Normally, its thickness is 4 to 8 millimeters.